If you need a shortcut to being deeply informed, you are in the right place. Welcome to the Deep Dive, where we tear into complex source material and deliver the essential insights you need to master a subject. Today, we're doing a foundational dive, pulling key concepts directly from Berek and Hacker's Gynecologic Oncology 7th edition. Our mission, really, is to distill the core science genetics, cell biology, treatment principles that defines the entire field.
It's so important to frame this because you have to appreciate how recently all of this knowledge came together. I mean,
Sure.
the subspecialty of gynecologic oncology really only formed in the U.S. around 1973. The progress since then has been, well, staggering.
So if you look back at that starting point, what are the big leaps that stand out?
Oh, three areas, for sure. First, imaging. The first specialists were working with, basic x-rays. Then came MRI in the 90s and PD scans in the 2000s. Suddenly we could see the disease in a way that was impossible before.
It changed everything for staging and planning.
Completely. Second, molecular biology. The Human Genome Project. That gave us the actual blueprint for the disease. It led to this absolute explosion of targeted therapies.
And I'm guessing the third is surgery, the practical application.
Exactly. The shift from huge incisions to minimally invasive surgery. First laparoscopy, then robotics. It just radically shortened recovery. I remember when a major surgery meant a week in the hospital. Now, many patients go home in 2 days.
It really gets to that core idea from the textbooks forward. Medicine as an art based on science. The compassion is the art, but the craft, the techne, that's what keeps getting bigger and better with all this discovery. And that's what we're diving into. Okay, let's unpack this. Let's start at the absolute beginning with the core definition. Cancer as a disease of the genome.
Right. At its heart, it's just a series of genetic alterations that lets a cell bypass all its normal safety controls. It leads to this unrestrained growth and invasion.
And where do these alterations come from?
They come from two main pathways. The vast majority, we're talking 80, maybe 90%, are sporadic. They just happen during a person's life.
So random chance or environmental factors.
A bit of both. Our bodies are incredible at repair, though. The natural error rate is something like 1 mistake in 1 billion base pairs. So our DNA repair systems are constantly working, but, over time they can get overwhelmed.
And that's where the sporadic mutations slip through. But the really high-risk cases, they often come from the other category, right? Hereditary changes.
Correct. These affect the germline. That means they're inherited, present in every single cell from birth. And for gynecologic cancers, the two big ones you need to know are HBOC, hereditary breast, and ovarian cancer syndrome, and Lynch syndrome.
So once these mutations start piling up, the whole system gets out of balance. It comes down to two teams of genes, the gas pedal and the brakes.
It's the perfect analogy. The gas pedals are the oncogenes pushing for growth, and the brakes are the tumor suppressor genes, or TSGs, trying to stop it.
So what happens when an oncogene gets stuck on?
You're usually looking at a specific type of protein on the cell membrane, a receptor tyrosine kinase, or RTK. These are the cell's antennas for picking up growth signals from the outside world.
So walk us through that. How does a signal outside the cell become this runaway train inside?
Okay, picture two separate protein units, monomers, just sitting on the cell surface. When a growth factor, the ligand, comes along and binds, it pulls those two monomers together. They form a dimer.
And that dimerization is the key step.
That's the switch. Once they're together, they reach across and phosphorylate each other. It's called transphosphorylation. And that action activates the part of the receptor inside the cell, which kicks off the whole signal cascade.
And that signal travels down a few major highways, right? The book mentions the MAPK pathway and the PI3K pathway.
Those are the big ones. Now let's talk about the brakes, the TSGs. For these to fail, you generally need to satisfy what we call Knudson's two-hit hypothesis.
Meaning you have to take out both copies of the gene.
Yeah, exactly. Both alleles have to be knocked out. In those hereditary cancer syndromes, the patient is born with the first hit already. One copy of the gene is mutated from birth.
So they're born with one flat tire.
Perfect way to put it. The car still runs, but if they get a random sporadic mutation, a second hit, in the other good copy,
The car crashes.
the cell loses all control. And these TSGs aren't all the same. The book breaks them down into categories like gatekeepers, which control the cell cycle, caretakers that handle DNA repair, and even landscapers, which manage how cells stick together. Okay, diving into those gatekeepers, there are two you absolutely have to know, PRB and P53. Let's start with the retinoblastoma protein, PRB. This thing is the ultimate roadblock for cell visit.
How does it actually stop the cell? What's the mechanism?
It physically latches onto another protein complex called E2FDP and just holds it hostage. This E2FDP complex is what the cell needs to turn on the genes for DNA replication. So as long as PRB is holding on, the cell is stuck in the G1 resting phase. It can't divide.
And we see viruses like high-risk HPV and cervical cancer that have evolved to specifically target and inactivate PRB.
It's a classic example. The virus produces proteins that just dissolve that roadblock, letting the cell cycle run wild. But if PRB is the roadblock, then TP53 is, well, it's the guardian of the entire genome.
It's the most famous one. Why is it so important?
Because it's the most frequently mutated gene in human cancer, period. More than half of all cancers have a mutated P53. Its job is profound. When it senses DNA damage, it slams on the brakes.
It stops the cell cycle.
First, it stops the cycle to allow for repair. But if the damage is too severe, P53 makes the ultimate call. It triggers apoptosis, programmed cell death. It eliminates the damaged cell before it can become cancerous.
So when P53 is gone, that entire safety net just disappears.
It's gone. Which brings us to the repair crews themselves, specifically the Mismatch Repair System, or MMR.
That's its job.
Its job is to fix the tiny errors, the little insertions, deletions, and mismatched bases that happen during normal DNA replication. The MMR system works like a little team. You have proteins like MSH2 and MSH6 that act as scanners. They slide along the DNA and find the mistake.
Okay, so they're the spotters.
They're the spotters. Then they recruit another pair, MLH1 and PMS2. This second team brings in the actual tools for the repair, like an enzyme called ECAS1 that snips out the bad section of DNA.
And the clinical connection here is huge. When that system fails, particularly if a gene like MLH1 is silenced.
The whole factory breaks down. You get this massive genetic instability throughout the genome.
And we can actually measure that. That's microsatellite instability, or MSI.
Exactly. It's a diagnostic marker we look for in endometrial and colon cancer, and it's a direct result of that broken mismatch repair system.
Okay, so now we shift from understanding the problem to attacking it. How does all this molecular knowledge translate into actual treatments? Let's start with targeted therapy.
Right. If the problem is a growth receptor that's stuck on, the solution is to find a drug that turns it off. We have drugs that target EGFR or HER1 and the famous HER2/neu.
Like trastuzumab for HR2.
Trastuzumab is the classic example. We also have smaller molecules like gefitinib and erlotinib that get inside the cell and block the signal from within.
And another strategy is to cut off the tumor's supply lines using angiogenesis inhibitors.
Yes, block the formation of new blood vessels. A great example is cediranib. It inhibits the receptors for vascular endothelial growth factor, or VEGF. And what's really interesting is that in ovarian cancer, combining cediranib with another drug, a PRP inhibitor called olaparib, showed a huge benefit.
But tumors are smart. They find ways to resist these drugs.
They're masters of adaptation. They can start pumping out other growth factors to compensate. They can hijack existing blood vessels instead of building new ones. They can even form their own channels in a process called vascular mimicry. It's a constant battle.
Which leads us to maybe the most elegant concept in modern oncology, synthetic lethality.
It is a beautiful idea. It means you have two genetic weaknesses that a cell can handle on their own. But if you hit the cell with both weaknesses at the same time, it's lethal. The cell dies.
And this is the science behind PRP inhibitors.
This is a genius of PRP inhibitors like olaparib and niraparib. PRP is an enzyme that fixes simple, single-strand breaks in DNA. It's a basic repair tool. When you use a drug to inhibit PRP, those simple breaks aren't fixed.
So they turn into something worse.
They escalate into much more dangerous double-strand breaks. Now, a normal, healthy cell has a great way to fix those, using a pathway called homologous recombination, or HR.
But a cancer cell with a BRCA1 or BRCA2 mutation.
That cell already has a broken HR pathway. That's its first weakness. So when you add the PRP inhibitor, the second hit, you've taken away its last line of defense. The DNA damage piles up, and the cell self-destructs. That is synthetic lethality.
It's brilliant. But chemotherapy is still a cornerstone, and drug resistance is a huge problem there, too. The book breaks it down into primary versus acquired resistance.
Right. Primary is when the tumor is just resistant from day one. Acquired is when it develops resistance over time during treatment. A big part of this is the cell cycle.
The dividing cells are the ones that are sensitive to chemo.
Exactly. The cells that are actively dividing are vulnerable. But quiescent cells, the ones just sitting there in a G0 resting state, which include a lot of cancer stem cells, they're relatively safe from the chemo.
And that's why we use combination chemotherapy. It's not just throwing random drugs at the problem.
Not at all. There's a clear rationale.
Yeah.
The drugs need to work by different mechanisms, and this is critical, they need to have different side effect profiles.
Why is that so important?
Because if you use two drugs that both hammer the bone marrow, you have to lower the dose of both. But if one affects the nerves and the other affects the bone marrow, you can give a full effective dose of each. You get maximum cell kill without completely overwhelming one part of the body. Now for physical therapies, let's talk radiation. Again, the primary target here is the DNA inside the nucleus of the cancer cell.
And when the radiation hits, how does the cell die?
Primarily in two ways. The most common is mitotic cell death. The damage is there, but it's only when the cell tries to divide that it becomes fatal. The other way is apoptosis, or programmed cell death, which can happen more quickly.
There's a really interesting principle here called the dose rate effect.
Yes.
Yeah.
This is all about the speed of delivery. If you deliver the radiation dose slowly over a longer period, normal, healthy cells have time to repair some of the damage as it's happening.
But tumor cells are worse at repair.
Generally, yes. They're less efficient. And we exploit that difference with something called low-dose rate brachytherapy.
Where you place the radiation source directly inside or next to the tumor.
Exactly. For instance, using a tandem and vaginal colpostats. You can deliver a massive localized dose right to the cervix while the dose falls off very quickly, sparing the nearby bladder and rectum. The rise of image-guided brachytherapy, using CT or MRI, has made this even more precise.
Okay, before we wrap up, we need to cover one incredibly practical, high-yield topic for any learner: carboplatin dosing.
Oh, this is essential. This drug is a workhorse, but it's cleared by the kidneys, so you have to get the dose right or you can cause serious harm.
We use the Calvert formula.
That's the one. The dose in milligrams equals your target AUC, or area under the curve, multiplied by the GFR plus 25. The AUC is usually a 5 or 6.
But there is a massive safety warning that comes with this: a cap.
A critical safety cap.
Yeah.
Because of how modern labs measure creatinine, the calculated GFR can sometimes be artificially high. So for the purpose of the Calvert formula, you should never use a GFR value greater than 125.
So if the lab says the GFR is 140, you plug in 125.
You plug in 125, period. If you don't, you risk a massive overdose. For an AUC of 6, for example, the maximum dose you should ever really give is 900 milligrams. Ignoring that cap is a major safety risk.
Okay, let's close the loop by bringing it back to diagnosis and risk. A pathologic diagnosis is key, and for cervical cancer, that starts with the Pap test, using the Bethesda system, often with HPV testing.
And the epidemiology for cervical cancer is it's crystal clear. It's almost all caused by HPV. But other factors play a role. Things like early pregnancy, having many children, and long-term oral contraceptive use. They all increase the relative risk.
In stark contrast, the risk profile for endometrial cancer is all about estrogen.
Unopposed estrogen, that's the driver. Which is why obesity is such a huge risk factor.
How so?
Fat cells peripherally convert other hormones, like androstenedione, into estrogen. In a postmenopausal woman, that estrogen stimulates the uterine lining without any progesterone to balance it out. The data is shocking. The book estimates that obesity is responsible for about 57% of all endometrial cancers in the U.S.
Wow. Just that one statistic really connects the deep biology to lifestyle risk. And that brings us to the end of a really packed deep dive. We've gone from the genetic mistakes that started cancer through the cell's own checkpoints like P53 and all the way to how we use that knowledge to design treatments. Grasping these mechanisms is it's everything for future practice.
It really is. And that leads directly to your final thought for today, a question to connect the dots. We spent some time on synthetic lethality and PRP inhibitors. For review, I want you to describe the mechanism that makes these drugs so effective in ovarian cancers with an inherited BRCA1 or BRCA2 mutation. What is the fundamental DNA repair pathway that's already compromised, which allows this class of drug to be so lethal to the cancer cell?
Think on that one. That's the kind of connection that makes all the difference. We'll catch you on the next deep dive.